Imagine mapping out every single public restroom on your running route, or being terrified to sneeze in the middle of a work meeting just because you might leak.
Yeah, it's a constant anxiety for so many.
It really is. And for millions of people dealing with stress, urinary incontinence, or SUI, that is just a regular Tuesday. We're talking about a massive, life-altering issue that, honestly, it rarely gets the airtime it deserves.
Right, people just don't talk about it openly.
Exactly. It's that involuntary leakage of urine that happens when pressure is put on the bladder. So laughing, coughing, trying to get a workout in. And for so many, when behavioral therapies and pelvic floor exercises eventually stop working, surgery becomes the reality.
It does. And if you follow pelvic health innovations, you know that for a long time, the surgical landscape has been, well, heavily dominated by one specific approach.
Right, the old reliable.
Yeah, the traditional gold standard has been the mid-urethral sling, generally referred to as the MUS. And this umbrella term covers a couple of well-established methods, specifically the retropubic approach, known as TVT, and the transobturator approach, which is known as TOT.
Okay, TVT and TOT.
Right. But recently, there's a completely different surgical philosophy that's emerged, and it's really challenging those traditional heavyweights.
And that is the single-incision mini-sling, or SIMS. And that is exactly our mission for this deep dive. We are taking the stack of clinical trials, the massive meta-analyses, and specifically the 36-month Altus 522 study to answer a very direct question for you.
Yeah, the big question.
Right. How does this newer, quote-unquote, mini-sling actually compare in efficacy and recovery to the traditional TVT and TOT slings?
It's a critical question because, on paper, the phrase minimally invasive always sounds like a major upgrade, right?
Totally. You hear mini and you think, sign me up.
Exactly. We inherently assume smaller is better. But the data reveals this really complex tug of war. We're looking at a delicate balance between significantly less pain and faster recovery time on one end and some highly unique localized complications on the other.
Well, before we even compare their success rates, I think I need to understand what a surgeon is actually doing during these procedures. What does the traditional mid-urethral sling involve that makes it so invasive in the first place?
So to understand the traditional approach, picture the pelvic anatomy. The core goal of any of these surgeries is to basically place a piece of synthetic mesh tape under the urethra to support it.
So it acts like a firm backboard.
Exactly, a backboard. When a patient coughs or sneezes, the sudden abdominal pressure forces the urethra downward. The mesh catches it, compressing the urethra shut against the tape, and that is what stops the leak.
Okay, that makes sense mechanically.
But the challenge is securing that tape. To get it in place with traditional TVT or TOT methods, the surgeon actually has to pass these long surgical needles either up through the lower abdomen for the retropubic route or through the inner thigh and groin area for the transobturator route.
Wait, through the inner thighs, you're essentially driving surgical instruments through multiple thick layers of tissue, structural muscle, fascia, just to secure this small hammock for the urethra.
Yes, and they are making a blind pass through the anatomy.
A blind pass. That sounds terrifying.
Yeah, well, that blind pass is the critical vulnerability in the traditional approach. And it brings us to a major clinical pain point. We have a really revealing 2006 study in our sources where researchers actually examined 24 cadavers following the placement of traditional mid-urethral slings.
Oh, wow.
Yeah, they performed these dissections because they needed to see exactly where these tapes were ending up anatomically after that blind pass.
And the findings there are intense. I was reading that in 25% of the cases, the traditional slings didn't just slide neatly into the connective tissue, they actually perforated the pubococcygeus muscle.
Right, which is this deep hammock-like muscle right at the base of the pelvis.
So 1 in 4 times, they are spearing this major structural muscle.
Essentially, yes.
Yeah.
And the clinical implication of that perforation is what really matters here. When you drive a rigid synthetic tape through a deep levator muscle like that, it doesn't just heal quietly.
I can imagine.
In a significant number of patients, it causes deep muscle spasms, chronic groin pain, and even, voiding dysfunction, where the patient has trouble actually emptying their bladder normally.
Right, because you're impaling a muscle that is constantly working to support the pelvic floor. The muscle is going to respond to that foreign object with inflammation and guarding, which perfectly explains why recovery from those traditional slings can be so incredibly painful for some women.
Exactly, which perfectly sets the stage for why the SIMS was invented in the first place.
Yeah. Right, the single-incision mini-sling.
Yeah. Devices like the adjustable Altus or the mini-arc, they were developed entirely to bypass that deep muscle trauma. So instead of needles coming out of the abdomen or the thigh, the FIMS uses a drastically shorter piece of tape.
Hence the mini.
Right. The surgeon makes only a single incision inside the vaginal wall, and the sling is then anchored directly to the obturator membrane or the superficial muscle tissue. It never penetrates those deep lateral adductor muscles in the groin, and crucially, no instruments ever exit the outer skin.
It fundamentally changes the surgical footprint. Like,
Right.
by completely avoiding those thick, sensitive muscle groups, the collateral damage to the surrounding anatomy is heavily minimized.
Exactly.
It's like, think about putting up a hammock in your living room. The traditional mid-urethral sling is like taking a massive masonry drill and running the hammock hooks all the way through the exterior walls of your house out to the brick, just to absolutely guarantee it holds the weight.
That's a great way to picture it.
Right. But the SIMS approach is like using really high-tech, heavy-duty anchors that only bite into the inner drywall.
The mechanics of that analogy are spot on.
Yeah.
You are relying entirely on the localized gripping strength of that internal anchor, rather than the sheer length and full thickness penetration of a long tape.
Okay, but seeing how that works mechanically, it honestly makes me wonder about the actual durability.
Sure.
If we're just relying on the drywall anchors, like if we're using a much shorter tape and we aren't drilling into those deeper, thicker structural muscles, does this mini sling actually have the holding power to stop the incontinence? Are we just sacrificing long-term effectiveness to make the surgical footprint smaller?
That was the exact worry among surgeons when SIMS was first introduced, like, will this actually hold up?
Yeah.
But when we look at the efficacy data, the clinical outcomes tell a really reassuring story.
Okay, what do the numbers say?
We have a massive meta-analysis encompassing data from over 3,300 women across 26 randomized controlled trials. And the overarching verdict from all that rigorous testing is that the SIMS procedure is formally considered non-inferior to the standard mid-urethral slings.
Non-inferior, meaning it holds its own perfectly.
Right.
Let's look at the specific numbers from that 3-year Altus trial, because the long-term follow-up is what really matters here. I saw that at the 36-month mark, patient-reported success was 72% for the SIMS group, compared to 67% for the standard sling group.
Yeah, so it actually performed a bit better subjectively.
And then when you look at the objective cure rates, these are, the clinical tests that physically measure urine leakage rather than just how the patient feels about it. The relative risk across most of these studies sits right around 0.98.
Right, and just to clarify, in statistical terms, a relative risk of 1.0 means two treatments have perfectly identical outcomes. So a 0.98 means they're practically neck and neck.
That's incredible.
Yeah, the short tape anchored shallowly in the membrane is doing the exact same mechanical job with the exact same success rate as the long tape drilled through the deep pelvic muscle.
But there is a massive caveat to that data that we really need to clarify for anyone researching this on their own, because if you dig into the history of mini-slings online, you will inevitably hit this wall of older data claiming they have terrible failure rates.
Oh, you absolutely will. And it requires understanding how medical data is aggregated.
Right.
We have to address what we call the secure anomaly.
Right.
Early on in the development of mini-slings, there was a specific device released called the TVT Secure. And its mechanical design was just fundamentally flawed. It didn't tension properly. And the anchors couldn't withstand the sudden spikes in intra-abdominal pressure from, like, coughing or jumping.
So it's just failing left and right.
It performed so poorly in trials, yielding these unacceptably high failure rates, that the manufacturer ultimately pulled it from the market altogether.
But because it was one of the earliest models, it basically dragged down the reputation of the entire class of SIMS devices for years, right?
That is exactly what happened.
It.
When researchers first started pooling all mini-sling data together for these big meta-analyses, the abysmal results from the TVT Secure made it look like the entire concept of a single-incision sling was just a failure.
Right. It poisoned the well.
Yeah. But when researchers isolated and extracted that tainted data from the discontinued device, when they looked only at modern, properly designed SIMS like the Altus, which feature adjustable tethers and far superior anchoring barbs, the data completely normalized.
Wow.
The modern devices hold their own beautifully against the traditional slings.
So if you or a family member are weighing these two surgical options, that distinction in the data is critical to know. You are not sacrificing your continence, and you are not taking a hit on effectiveness just to get a less invasive procedure. The modern drywall anchors hold the hammock just fine under pressure.
They do. And if both surgical methods are virtually tied for how well they stop the leaks, the deciding factor for a surgeon or a patient shifts entirely to the recovery room.
Let's talk about that recovery payoff, because time is quite literally money here, and comfort is paramount. Starting with the speed of the surgery itself, the clinical data shows that placing a SIMS averaged just 15.8 minutes.
Compared to 25.4 minutes for the traditional TOT sling.
Right. And a 10-minute difference might sound totally trivial in everyday life, but in an operating room, I mean, that is a significant margin.
It's a huge margin. A shorter procedure means less time under general anesthesia, less time for internal tissues to be exposed to air and potential infection. And the data clearly reflects this by showing a significantly lower volume of intraoperative blood loss with the single-incision method.
The real advantage, though, seems to be the reduction in pain. We discussed that cadaver study and the frequent perforation of the deep pelvic floor muscles. Because the SIMS completely avoids passing through those adductor tendons in the groin and it never exits the skin, the drop in postoperative pain is just staggering.
It really is.
The data calculates a relative risk of just 0.30 for groin and thigh pain when compared to traditional slings.
Let's contextualize what a 0.30 relative risk actually means for a patient waking up from surgery. It means that by opting for the SIMS procedure, the risk of experiencing that debilitating groin and thigh pain is reduced by 70%.
70%. That is massive.
It's a massive improvement in immediate postoperative quality of life. The patient isn't battling deep muscle spasms every single time they try to stand up or walk.
And that lack of deep muscle trauma translates directly into getting back to life faster. Patients who receive the SIMS return to their normal, everyday activities a full 5 days earlier than the traditional sling group.
Right.
And more impressively, they return to work 7.2 days earlier.
Over a week earlier. I mean, the socioeconomic impact of accelerating a patient's return to work by a full week cannot be overstated.
Absolutely. For so many patients, a week and a half is the difference between needing to drain their entire paid time off balance for the year, or worse, losing an entire week's paycheck if their job doesn't even offer PTO.
Yeah, that financial toxicity is real.
Right. For hourly wage earners, for single parents who have to arrange childcare, or for anyone whose job requires them to just be on your feet all day, a recovery that is 7.2 days faster is often the deciding factor on whether they can even afford to have the surgery in the first place.
Exactly. We so often look at medical innovations strictly through the lens of, like, biology and clinical outcomes, but the financial burden of prolonged surgical recovery is heavy on patients. The single-incision approach heavily mitigates that burden by respecting the surrounding anatomy.
But we know nothing in medicine is without trade-offs. If the SIMS is faster to implant, results in 70% less groin pain, saves you a week of missed work, and is statistically just as effective at stopping the leaks, what exactly is the catch here?
Well, the catch is a fundamental principle of surgery. When you change the mechanics of an operation, you rarely eliminate complications entirely. You simply shift them to a different anatomical area.
Right.
And the SIMS trials highlighted a very specific, different issue, with 12% of women in the SIMS group reporting dyspareunia, or painful sexual intercourse.
Wow.
Compare that to only 4.8% in the traditional midurethral sling group.
Hold on, 12%. So we successfully spared them the deep groin pain by not drilling through the thigh muscles, but we effectively traded it for a complication that could severely impact their intimate relationships.
Yes.
That feels like a massive trade-off for a patient to navigate.
It is the central clinical dilemma of this device. To understand why this happens, you have to look at the placement. Because the SIMS is anchored directly into the internal vaginal tissues and the obturator membrane, the tension and the resulting inflammatory healing response are concentrated entirely within the shallow vaginal wall.
Which is very different from the deep muscle anchoring.
Exactly. The vagina is a highly dynamic organ. It needs to stretch and move. But when you place a rigid synthetic anchor right in that superficial tissue, it can create a localized point of stiffness or scar tissue.
I see.
So for about 1 in 8 women, that concentrated local tension translates to friction and pain during intercourse. You spared the deep muscles of the groin, sure, but you placed a much higher structural burden on the vaginal tissue itself.
And it's not just the pain either. The data notes that mesh exposure, which that happens when the synthetic tape actually erodes through the vaginal skin and becomes exposed in the vaginal canal. That was slightly higher with the SIMS.
Yeah.
It was 3.3% versus 1.9% over 3 years. And while the 5-year failure-free rates are similar between the two, some data sets are showing a trend toward a higher need for repeat continence surgery with the SIMS down the road.
It brings up the harsh reality of implanting foreign materials into the human body. The body is dynamic, it moves, it heals, and sometimes it actively rejects what we put inside it.
There is a highly specific clinical anecdote in our sources that I feel perfectly captures this reality. There was a patient who developed recurrent stress incontinence 3 years after her SIMS was placed. And when the surgical team went in to investigate why the sling had failed, they didn't just find that the tape had slipped.
No, they found a 1.7 centimeter bladder stone.
A rigid stone nearly 3/4 of an inch across just sitting right in the surgical set.
That's wild.
And this stone had formed entirely around the polypropylene barb of the SIMS implant. It turns out, if you put heavy-duty anchors into the drywall, sometimes the body reacts to that intrusion. In this case, the anchor acted as a nidus, a focal point. The body recognized this foreign plastic barb and spent 3 years slowly calcifying minerals around it until it formed a massive stone. The surgeons actually had to do a transvaginal excision just to cut out the mesh, separate the stone, remove it, and then the patient had to be sent home on continuous catheter drainage just to allow her tissues to heal from the removal.
It's a stark reminder of the stakes involved here. While the SIMS is wonderfully minimally invasive on day one, that small polypropylene anchor is still a permanent physical object living in a very active, highly sensitive part of the body.
Absolutely.
The body will interact with it over time, and sometimes it does so in highly unpredictable ways, like calcifying a stone around a plastic barb.
So for anyone listening who's looking to be well-informed on pelvic health innovations, where does this leave the SIMS? The single-incision mini-sling represents this brilliant leap forward in minimizing deep tissue trauma. It saves operating time, it drastically cuts down intraoperative bleeding, and it shaves a full week off the recovery timeline, all while maintaining continence rates that rival the older, much more invasive slings.
However, choosing it requires a deeply personalized conversation with a doctor. A patient really has to weigh the near elimination of debilitating groin pain against the statistically higher risks of mesh exposure and painful intercourse. It is a highly refined tool, but it definitely has its own distinct set of edge cases.
It really comes down to picking which set of risks you are most comfortable living with. But there is a broader concept here that I think is fascinating to consider as we wrap up. We've spent this entire deep dive looking at 1 to 3 year data, and in that short-term window, the SIMS looks fantastic. But medical devices don't just live in the body for 3 years. When you implant a synthetic sling, the goal is for it to remain functional for decades.
Which raises the ultimate question for the future of all surgical innovation.
Yeah.
As we continually push to make implants smaller, shorter, and less invasive, purely to speed up the recovery times of today, are we potentially sacrificing the anatomical durability that the human body requires 10, 20, or 30 years down the line?
Right.
It's a high-stakes balancing act between designing for the rapid recovery of right now and the enduring medicine of tomorrow.
We are so focused on not drilling through the exterior walls of the house today that we have to wonder, are those drywall anchors still going to be holding up the hammock a decade from now? Something for you to think about?
No.